Good evening, everyone. On behalf of the Bombay Ophthalmologists Association, I extend a warm welcome to all of you all for our first of our master classes. Now, we plan to have these master classes basically so that it could be something which we can learn from people who are doing something more than what we are doing. And this extends beyond the normal learning. It is something like taking it back into the Guru Shishya Parampara. So today for our masterclass, the first masterclass of this year, we have with us none other than Dr. Deepak Megur, who actually requires no introduction. But I'll just give you a few of his. Dr. Deepak Megur is a prominent and a prolific phacosurgeon from the Megur Eye Institute from Bidar in Karnataka. He is the winner of the ASCRS 2023 Best Video Award. His other awards run into probably 2 pages, but a few of them would be the Lifetime Achievement Award of late Nilima Paude Lifetime Achievement Award in 2022. He's won the CS Reshmi Overall Best Video Award at the AIOC 2020, Best Paper Session in AIOC 2018, and also he's the Best Overall Paper Award in 2010 in AIOC, as well as the MM Joshi Overall Paper Award in 2009. So before wasting much time, I think there is a lot which Deepak wants to show us with his excellent videos. His videos are something which quite a few people amongst the younger generation follow on YouTube. He runs a YouTube channel and a website called phacotraining.org. And so without wasting any further time, I think I'll hand it over to Deepak to take us through this webinar. The pattern.
Thank you, sir. Thank you for
the pattern which we'll keep for this is that after every case of Deepak's, we will have a short panel discussion so that we can take questions from the audience and address it to the panel, as well as we can get comments from all our panelists. So amongst the panelists have Padam Shri Dr. T.P. Lahane, Dr. Sandeep Nagvekar, Dr. Suvira Jain, Dr. Nitin Malkan. Dr. Ragini Parekh was also supposed to join, but due to some personal reasons, she has told us that she would not be able to join in this webinar. And so without wasting further time, I hand it over to Deepak.
Thank you, sir. It's a pleasure to be here among all of you, and all of my teachers are there here, seniors whom I have looked up to and learned a lot from you all. So I'll be starting my first presentation. I'll be sharing my screen, and the first one would be, it's intended primarily at the newer surgeons, like, who usually find the soft cataracts to be hard. The experienced surgeons definitely find a way to come out of this situation, but it is a problem which bugs all the newbie phacosurgeons a lot. The fun of the simple reasons we need to understand is that all soft cataracts are not same. Okay, so that one thing which you need to remember. And you cannot have a single strategy for all soft cataracts. So let me just share that, soft cataracts in young, less than 40, these lenses are much more gummier and much more easier to manage. On the contrary, the soft cataracts which we encounter in the 50 to 60 year age group can be tough. Some of them are purely cortical cataracts. They don't have any nuclear sclerosis, so that you cannot hold them. And especially the diabetic cortical cataracts, they're really crumbly cataracts. So these are the situations which can be challenging. The most common problem which we encounter is unable to chop, crack, because we're unable to hold it. And invariably, we have a bowl formation, and that's a very sticky situation to be in. So there are only 2 simple principles, you need to understand that the bigger your excess is, and if you have a good hydro procedure done, most soft cataract can be dealt with very easily. The problem comes when you don't have this, you don't have a bigger excess, and your experience level is slightly lesser. Then you need to have a definite, strategy for this. And that's what I'm going to take you through. If you are stuck in a situation like this, just take you through some common scenarios where we have soft cataracts and different ways to manage them. Now, this is a 45-year-old person, a 45 or 50, cataract is soft, you do a good hydrodissection. The rexus size, if you can observe, it's optimal. Like, it is about 5 millimeter. You get a good hydrodelineation done. And this is an ideal case scenario to try the carousel technique, wherein you're not going to break the nucleus. You just hold the epinucleus, eat it up, and then with just a little bit of power, engage the entire endonucleus mass. And once the size decreases, the entire mass flips out of the bag, and you can very easily emulsify in the antechamber itself. It's a very easy case because you have got some sort of a nuclear substance in it, and you are able to get a hold, you're able to achieve this. Now, this is a second case scenario. Patient is a 30-year-old lady. And again, these are very soft cataract. The cataract is very gummy. It's not difficult. These are not crumbly. Once you get a hold, you can literally hold them and move around with them. You can engage them, you can reduce the size and then flip it out of the bag. These are situations where, in spite of the rexus being slightly in the smaller variant, you can still get away because the nuclear size is slightly lesser and it is not crumbly. Like, it comes en masse. So the younger patient is very easy. Now, coming to the more difficult scenarios. Now, this is a case with maybe 60-year-old gentleman who has a softer cataract. The pupil I've taken care of, the rexus is decent size, 5.5. You've got a good hydrodissection done. And the first thing, I am not expecting any problem in this patient. It seems to be a very routine case. The moment you go ahead and try to hold, to bury your phaco tip, then you realize that it's a crumbly cataract. In spite of using very less phaco power, you are able to get a purchase, but you're unable to divide it into smaller fragments. See, so I switched to, the just sculpt it, divide into 2 fragments, and then pull one of the heminucleus out. Now, what happens here, even that doesn't crack. So now we have a situation where it looks like a bowl now, and we have a rexus which acts like a deterrent. In this case, what we need to do is just keep on eating at the endonucleus mass, rotate it, and keep on and eating at it. So the aim is basically to reduce the mass of your endonucleus, and eventually you flip it out and eat it. So that is the secret. The problem really is if the visualization is not great and the rexus is slightly smaller, then we have a situation. But the trick here always, one of the things which we've encountered, people are using the Alcon machines. Settings do play a role. You can't engage this soft nucleus by using a torsional energy. You need to switch it to longitudinal. And if you're already using a longitudinal energy, just reduce it. So this is something which one need to understand, play with the parameters. Again, a soft, crumbly cataract, you just can't get a hold of it. And you try to search and try to get one denser part where you want to bury your tip and prove it. It's just not possible. See, the one important reason what you need to understand here is that rexus is the primary deterrent for the epinucleus or the nucleus to flow out. Now, because we have already done the rexus at the right 4.5 or 5, which might not be ideal for this case scenario, or in situations where you want to plan a multifocal or toric, you are forced to use a smaller rexus itself. You can't make a bigger rexus. In these situations, we need to be ready with our strategies now. So you have to somehow manage to reduce the size of the nucleus. In this case, one of the safer best, you can always go ahead and try this, is try to make a long sculpt in this and try to divide it. So once you have 2 heminucleus, it will not be much difficult to pull one heminucleus out of the bag. Again, when you want to pull it out of the bag, use a longitudinal energy in a burst mode, in a very small amount, maybe 5% or less than that, and then hold and pull it. So for beginners, I would say whenever they're suspecting, a softer cataract, if they're inexperienced, best strategy always is to go ahead and do the stop and chop, or just create a long, thin trench. To get a long trench, you want to expose the tip slightly bigger so that you don't have to compensate for the sleeve as well. So if you have a thin, long trench, you are less likely to cause a bowl formation. And once you have got 2 of these fragments, then it's a cakewalk. Getting it into 2 heminucleus is the challenge here. So sometimes then if you are lucky enough, you are able to get these 2 heminucleus, then divide it into just 4, or you don't have to divide, just pull out the entire heminucleus out and you can emulsify. Invariably, the nucleus will be very soft and you can just emulsify in the anterior portion also. Now, something which I am working on a newer concept is in this again crumbly cataracts where you're unable to divide them or even laterally separate them. The one principle which I'm following is the what I call as the double wide technique. You make a small long trench as usual. The only trick here is I'm trying to make a slightly wider groove in the most peripheral part. It looks like a Y. So you are having a broader ends and the central narrow trench is here. The principle is here, the reason why I'm doing like this is if we want to flip, we want to hold it at the peripheral edge. The one of the reasons why the nucleus doesn't come out of the bag is there are two resistance. One is the heminucleus abutting against themselves. Second is the rhexis. The rhexis is already done, which we cannot change. So what we can change is the two heminucleus jam packed towards each other. So I'm just trying to, widen the most peripheral part. And then the trick is not to hold it the mid-peripheral central part. Hold it at the end of the heminucleus where the resistance is the least. Just engage it and then you can flip it out of the bag. So once the heminucleus comes out of the bag, it's again a cakewalk. So that is one secret here. Just hold it near the edge, not in the center. So you don't face the resistance of this of the rhexis overlying rhexis margin. I think that was it, and you can just have a discussion on this.
Thank you, Deepak. That was very, very important points and very simply elicited. So let's take this up to the panel.
Sure.
I'll ask Dr. Larne what he does normally in such cases of soft cataracts. Sir, you're muted.
Basically, what Meghur showed the cases, except the double Y, I am doing all techniques here. And what he says is very true. See, I teach my residents since first day that when you are doing a soft cataract, your rhexis should be larger. So again, I say two places rhexis should be larger. One is at the soft cataract and one is at the nuclear hard cataract. Because here in the nuclear cataract also, when you are making the pieces, that also gives you trouble when the rhexis is not large. So very correctly Meghur has told. And secondly, I think his teaching is correct. So once the nucleus comes out of the bag, then there is no problem. So, and making two pieces. So really I appreciate Deepak, both all the three things, all you have taught is very true. And basically, whenever you are learning, I always say that you choose a nucleus where there is a nucleus is formed. Don't choose a nucleus where there is no nucleus. When you will choose such type of case, then you had it. So choose a case where there is a nucleus and first learn all these things when there is a nucleus. So you go for the NS2 cataract, not for the NS1 cataract. And once you go for the NS2, then it is easy because breaking the nucleus in two is very important. And secondly, again, I think Deepak, you must, add in that the cataract is not a cataract done by the fast technology. What happens? Everybody feels that once the phaco probe comes in the hand, then it should work like 120 or more than that speed. So I think that speed should be less in case of the soft cataract, and that less speed will help you in the soft cataract. But really, I appreciate Deepak. Thank you.
Thank you, sir.
We have some questions from the audience as well.
Yeah, Karishma.
One of them has, we also, I would like to announce that we have somebody from Pakistan who's doing a job in Tanzania who has joined us right now. One of the questions that have come is how to avoid or release conjunctival ballooning during the phaco through the limbal or neoscleral incision. Would anyone from the panel like to take that?
Suvira?
How do you avoid? How do you manage?
Yes. I think that conjunctival ballooning, here what happens, why there is a conjunctival ballooning? Because your incision, when you are taking incision in the cornea, so you are just behind. And once you are just behind, then whatever the fluid is coming, normally from the main site of the incision or from the two side ports, it goes in the conjunctiva, in subconjunctival tissue. The best is to give a nick in the superior portion where it is covered by the lid and remove all the fluid, automatically it comes out. So basically, whenever you are taking the incision, it should be slightly ahead of the where the conjunctiva is, you can say, inserted there, and then ballooning you can avoid.
Any other questions, Karishma?
Can I make a point about the
Sure, Nitin.
Awesome.
Yeah, that was wonderful videos showed by Dr. Deepak. You know, the trick here is the PHACO power, what you correctly said, that it has to be longitudinal, and one has to be very careful in a soft cataract. But this is true when you are an experienced surgeon. Many a times the juniors make a mistake, and while holding the periphery, invariably, you land up with the PC rupture. So what I suggest is to do a visco expression of the ball when you have formed, inject the visco underneath the axis, and automatically the edge gets elevated. Then you manage and you can easily phaco.
Sandeep, your views?
Well, I think most of the points are covered. The only thing I would like to impress upon people is that when they're making a trench to divide into two, the trench should be narrow as opposed to a wide trench in a hard cataract. And when you're splitting, sometimes when you're doing the crack, if you keep your probe, if you're a right-handed surgeon, keep the probe on the right side and keep the dialer or whatever chopper instrument on the left, you may not get a crack. At that time, if you can do a crossed crack, it will work much better. It will be more efficient also, because if you dip down, the nucleus being soft, you are unable to reach the bottom of the plate. So you can probably try the other way. But make a narrow trench, not a wide trench.
Yes, Suvira.
I would completely agree that even for us, sometimes as reasonably experienced surgeons, managing soft cataracts is far more challenging than a cataract that has a nucleus which will actually crack predictably. So what I think and what I actually think is that we should have a technique that is reproducible each and every time. So in my hands, what I have found is when I have a very soft cataract, as long as I have a rhexis, which is 5.5 millimeters, 5 to 5.5, which is enough to give me a concentric cover of the optic of the IOL eventually, I just perform a good hydrodissection. And while doing so, I just pop the nucleus out of the bag. Now it's very, very soft, so I almost never need to use any phaco energy. So I'm not concerned about damaging the endothelium, because once my nucleus is half in the AC, I put some visco and that to a dispersive behind it and above it and hold it in the elevated position, and I virtually downsize and emulsify, or rather aspirate it. And it's predictable and it's safe, and it's also easy for us to teach because all surgeons who bring SICS are quite good at prolapsing nucleuses. Thank you.
Very good point.
If I may add one more small point, in very soft cataract, say the age between 30, 40, I prefer to do hydrodelineation always and identify the nucleus, which is so soft, so that you avoid going to the periphery. Just emulsify the nucleus with lowest parameter, and then you can manage the remaining part of the cortex with irrigation aspiration probes also. It may take little longer, but then you can avoid all the dangers of piercing the PC.
Good point. Good point. So I think.
Can we take one more question, or shall we move to the next video?
Is it regarding a soft cataract? Then we'll take it right now.
We can, no, it's a next one. We can go to the next.
Take it to the next video. Deepak, we'll go to the next topic.
So now we'll go to the other extreme. Other extreme is the dense brown black cataracts, and here the real challenge is how we deal with the posterior plate. Okay, so we can chop the upper part, but the bottom posterior plate, that is the last 5%, is extremely difficult. The most critical thing is to place your second instrument as deep as possible, I'm engaging the phaco tip there and moving my chopper as posterior as possible. You can see that the most of the part is broken, but the central 3 mm zone, it just refuses to budge here. Okay, now this is the challenge which we have. And let me pause here. Most complications for managing hard cataracts happen when you're trying to break the nucleus into smaller fragments. Either it is a rhexis tear or postcapsular tear or zonular dehiscence, because we're so much, we have to manually use so much force in spite of going so deep with your trench as well. So the central 4 mm, 3 mm is the real challenge. And in spite of trying to place my second instrument as deep as possible, it's still difficult. So now this is the most frustrating aspect of dealing with this. But one trick which I have found out lately, which you might all try and let me know, is that somehow you have to get rid of one piece there. Now what I'm trying to do is the one piece I'm just trying to emulsify. Its root is still not cut. The superficial part is cut. Now what is created is, it has created some sort of a space in the bag. So among the four pieces, one is out now, one space is there. You fill the bag with OVD. Now, using a Sync, what I'm doing here is I'm just gently pulling up the central bridge, which is holding all these three fragments together. So what I'm doing, basically prolapsing this posterior plate up. This is possible only because I've got space within the bag. Now, this is the central zone. This is what we call as the sangam. All the bridge, this is the bridge which is attaching all the three fragments. Now, it is far away from the posterior capsule. It's at the level of the rhexis margin, very accessible to us. So what we do here is just go in and phaco that part without using any mechanical force. Just do sculpting, just do regular sculpt settings. Now, because you can sculpt because you're very far away from the posterior capsule, there's no damage to any of the structures. And very effortlessly, you're able to break that bridge, which is holding all these two fragments. And once that bridge is broken, then the eating of these fragments is a very simple task. So I just tried this, and believe me, it's quite predictable. The only, this again, a rock hard cataract, it's maybe grade 5, grade 6. And the biggest challenge is we always miss out on how deep we can be. We think we are deep enough, but eventually find out that we're still not deep enough. Now here in this cataract, just as Lane sir was pointing out the size of rhexis, look at the size of rhexis. I've created a rhexis almost 6 mm large so that I don't impart any stress on the rhexis margin here. The peripheral part of the posterior plate cracks, whereas the central part continues to hold on. Okay, so that's the challenge. I'm using 2 long Sync so that I can have a very good reach up to the posterior plate and then stretch it. So I'm very mindful of that, and I'm not also stretching on this thing. Again, the same trick I'm tracking here. Central portion is not cracked yet. So somehow I'm going to pull one piece out of the bag and eat it. It's not complete. I'm going to eat just 2/3 of this 1/4 fragment which I've created. So what we have now, again, the posterior plate which is attached centrally is still there. Refill the bag. In this case, the amount of space which I needed to prolapse the bridge out is still not there. So I need to go ahead and try to separate at least one more part. And in this case, I'm using my Sync to just mechanically lift up that whatever posterior plate was there. So now the posterior plate, which is bridge, is all prolapsed out. Again, you're going to phaco this. What I call this technique is the flip and phaco the base. Flip up the posterior plate and then phaco the base. So for the prerequisite for this is you need to create some space within the bag so that then you can maneuver this out. So once we have eaten up all these, the bridge which is attaching all these 3 fragments, push them back down again into the bag and then emulsify. This is the last piece, last 2 fragments are still attached. Again, then push them up a little bit and expose the bridge, eat the bridge off, and then all these fragments are separated. So the basic principle here is that we're not using severe mechanical force to fracture it. So we are somehow trying to expose that part, bring it to a more place where it is amenable or which is reachable, and then we're going to emulsify it. Again, this is a tough case, non-dilating pupils, pseudoexfoliation, and again, a grade 5 or grade 6 cataract. So first you try to do lateral separation in a traditional way and try to separate at least one fragment out here. So that is the goal here. Once you've created one fragment out, you can literally pull it out and then emulsify at the level of the rhexis margin. The secret of having clear corneas on the first post-op day is to being very slow. No, that is a secret. You have to ensure that the plane of emulsification is at the level of the rhexis margin or of the iris, not anywhere near the anterior chamber. Of course, refilling the chamber repeatedly with OVD is going to help us. Again, the same principle. You have a nice space here. Fill the bag with OVD and mechanically prolapse that bridge which is holding it, or the sangam, and then you're going to separate it. In this case, I could separate it just using 2 Sinskuk itself in a very safe plane. It is far off from your posterior capsule. So by doing this small change in the one procedure, I think we are much better off, and it gives a much safer option when you're trying to divide this posterior plate. If some of the fragment which is not there, again, you go back, flip it up, and flip the base. This is what I call it: flip it and phaco the base. So the two of the fragments are still attached. The posterior plate is now exposed up because it is flipped. But mind you, the nucleus is still in the bag. Only thing is the posterior plate is now at the level of the rhexis margin. So you are still far off from your corneal endothelium. You're not even in the anterior chamber, just maneuvering at the level of the rhexis margin and then emulsifying it. And once you have done that, then the other fragments emulsification is going to be very easy and safe. These were my few tips on dealing with the posterior plate in these ultra dense cataracts. Thank you so much.
Thank you, Deepak. I entirely agree with you about the central piece. In fact, I do something similar, but in a slightly different manner. I keep eating off the periphery, not only in one quadrant, but almost all 360 degrees. And then I pick up the central piece with a little bit of a phaco power. I just try to lift it up. And once that comes up into the plane of the rhexis, I chop it. The same video I had shown, I was a award winner at the ASCRS many years ago. So basically the principle, what you are demonstrating, is the same, but I entirely agree with you that it's a hard central core, the endonucleus, which is what troubles everyone. So coming to the panelists, Suvira York, your points about. You're muted. Suvira, you need to unmute yourself.
If I talk to students for this last patient that Dr. Meghoor showed, I'd probably ask them to do an SICS, because young students, young phacosurgeons are not going to be able to manage the power modulation. They'll only be interested in getting the cataract out, and anyway, starting surgeons use a lot more energy. So I would advise them to do an SICS here. As we get better and when we are managing hard cataracts, my preferred technique of choice is a direct vertical chop, wherein I'll use my tip, which is the best in my set that I have. I will expose the tip more. I'll have the longest chopper, which is about 1.75 millimeters. And the way I'm able to get to almost 95%, as Dr. Meghoor showed, is by doing a multi-layered chop. So I'll do a chop. It'll partially separate. I'll go in that same plane that I've chopped. I'll hold on deeper there, engage, hold, and I'll laterally separate. So now my tip is also lower down. So is my second instrument. And yes, we are more often than not left with that little shred, which whatever you do, it does not turn. I feel that in my hands, it is safer even if I've got maybe out of the 6 fragments, 2 which are connected to each other, or 3, I would start to bring it up, that little flower up, and on its way up, I will eat it up. I find that personally, that's safer in my hands than going and lifting it up, and definitely in the hands of students. But I think I'm going to try Dr. Meghoor's technique now. Thank you.
Sandeep, your.
Can you hear me? Yeah.
Yes.
Yeah, so I agree with everything that Dr. Meghoor said. And for those who are learning, trenching in a hard cataract, I would advise them that let the phaco tip do the emulsification rather than drag down. Many of these cataracts, the capsular bag is entirely filled with the nucleus. And I've seen many people, when they're doing sculpting or doing downslope sculpting, are putting unnecessary traction on the zonules. So these are cases where already the zonules are weak. Most of these people are elderly people. So one thing that you have to know, that whether you are trenching, whether you are chopping, or whether you're doing lateral separation, make sure that you're not putting too much stress on the zonules. And yes, as I said earlier, the trench should be wide, it should be long, and it should be deep. Very often people in a soft cataract are scared to trench, but here you should not be scared to trench because you can go down as much as you want. And as we said, the cataract itself is not cracking very easily at the posterior plate. So go down as much as possible. And when you're cracking, make sure that you are putting your both instruments deep down in the ridge and then exerting a lateral separation. That's a few things that I'd like to add.
Nane, sir?
Basically, what Deepak showed, I agree with him, and what I think maximum thing though both have covered. The what Suvira said, the when such type of cataract comes, for the student, I always tell them go for SICS. I never tell them go for the PHACO till they are lecturer. Once they are associate professor, then they are permitted to go for such type of cataract. Secondly, these are the leathery, rubbery fibers in the posterior zone of the black cataract. And as you know, I am from Latur. The maximum black cataracts are there in Latur. So those cataract, now what you showed is a trenching in 4 quadrant trenching. Yes, we should go for that because the you can debulk it. The second thing is one of the trench should be deep. So whenever you are making the trench like cross, one trench should be deep and larger. So once you go deep in one trench, then you can see making one piece is never help in such type of cataract. You make first 2 pieces, and once you make 2 pieces, then the struggle is over. And for that, how to make the 2 pieces? So you start separating from the periphery, it comes, and here it doesn't separate. Then you go on the other side, also separate, and in the center it is not separate. Now here your instrument should not be away from each other. So that will what will happen? Then they will dip the portion of the nucleus down, and you will have a tear, and you will not understand why there is a tear. That is a force. That force has teared it. Always better that this both instruments should be like this, near to each other, and then only the tips are like this. See, the tips are like this, and by that you separate the central portion. One on the phaco tip and other is your chopper, and you separate it like this there in the center, and in the minimum space it will get separated. Once that is separated and two halves are made, after that, then you can have you already you have trains. Then you can make the pieces. It is not complete piece also. What you said is correct. You take one piece that will make a space. That is true. That time it may not be separated. Second thing, what can happen when you have taken that piece out, make it upside down. Automatically it happens. And from posterior you can cut it. Posterior, if you cut it, then it automatically goes because that is the you can say the rubbery and leathery fibers. So making 2 pieces is more important than making one piece. Make two halves of the nucleus and one trench should be deep. And in that, use instrument nearby. So this is all making 4 pieces. You can say the this chopping technique in the nucleus, this type of nucleus doesn't work. You will have to go stop and chop. So that stop and chop will definitely work in such type of cases. And I do the such type of cases. I think every day maybe 10 or 15 cases I operate such hard cataract because all cataracts which are hard and those come on my table. But I think normally the PC tears happen definitely. I'm not God that I'm not having the PC tear. Also the one on one day there may be 3 nucleus in the you can say vitreous. I have put 3 nucleus in the vitreous and Siley and Pritam they were removing. So this thing all happens. But only thing is that make 2 pieces and when important thing here is instrument should not be away from each other. Only you should use here, separate it. Don't use more space for separating and you will see the sound click like that. That is separated. And once you cut, you can see the 2 pieces are separated, and then the nucleus is easy to take out. This is what I want to add.
Thank you, sir. I think we'll go to the next. Yeah, Karishma. Karishma, you need to unmute yourself.
We have a question regarding detecting an intra-op PC tear. Deepak sir, are you going to be addressing that separately, or would you like to take that question right now itself?
No, I don't think in the agenda we have a talk on PC tear.
Yeah.
But detecting PC tear after the nucleus is removed is quite easy, because you see the tear margins in the red glow. So that is very easy. But the challenge really is how to diagnose a PC tear with an overlying nucleus. When the nucleus is not there, the PC tear actually is visible to you because the red glow is there. You can see the delamination of the PC tear, and sometimes you can see the anterior rupture also. And once the vitreous comes out, the shape of the PC tear changes. It was round before, it becomes oblong, and you can see the rhexis margin becomes stretched. These are you identify PC tear when the view is good. But the challenge is when the overlying nucleus is there, how do you diagnose PC tear? That's a really big challenge. So one of the ways is to early detection is if one of the fragments is a slightly at a lower plane than the other, then it is probably you can indicating. See, the classical teaching of poor followability as an indicator for presence of a vitreous, it is too late. By that time, the vitreous is already prolapsed out. So we need to diagnose it as early as possible before even the anterior has ruptured, when the nucleus is still there. So the classical findings would be the nucleus doesn't rotate so easily well. The second thing would be with the fragments. One of the fragments
Once you are
slightly
just
tilting
behind,
down.
then
This is
what
the stage when the PC tear has happened, the anterior still has not ruptured, vitreous is still not come up. Once the vitreous has come up, it's very easy because suddenly the fragments move away and far away, and they may fall down. So identifying the PC tear with an overlying nucleus before even the vitreous phase is ruptured, that's a challenge. Two signs. One, look at the nuclear fragments. If one of the fragment is slightly at lower place. Second, nucleus rotation becomes difficult or nucleus starts to tilt. These are ominous signs.
Okay, I think let's go to the next case so that
Yes.
we can see more of the excellent videos.
So I think next talk is about the pseudoexfoliation in small pupil. And so we need to remember that pseudoexfoliation attacks multiple structures in the eye. It is just not about the antercapsule or the zonules, the angles. So the material is dispersed everywhere and it causes pathology everywhere. So two primary concerns for cataract surgery is pupil and the zonules. Okay. So some strategies to deal with the poor mydriasis is you use pharmacological agents which are available, like phenocaine plus or other alternatives, or you can use viscomydriasis. Just use a heavy viscoelastic, that also would be fine. The stretch pupilloplasty in moderately dilating people you can use. But the flip side is sometimes when you stretch it, it can become very floppy and causes bothers us later on. The microsphincterotomies is the one which we used to use many years back, and the only disadvantage is you will not get a very big dilatation, but it prevents intraoperative meiosis. But what we currently teach most of us is that never hesitate to use the pupil expansion devices like the iris hooks or the ring-based devices. And the advantage of using a ring-based device is that you don't have to make the additional ports. So in India, we currently have two variants. One is the BX device, and second is the Gupta ring, which is almost a mimic of the original Malugin's ring. So the BX ring, what I use most often than not, and this is one such case, because it's very flimsy and thin, it might not be very effective, the BX device, in very rigid pupils. So in some situations, I do stretch pupilloplasty so that it's easier and it stretches more when I insert the BX device. That's one thing. So in very shallow chambers, or the lens is very much touching the iris, one small trick is to put a little bit of OVD under the pupil, just a little bit, not much, so that you don't damage the antercapsule when you're trying to negotiate the BX device engaging the notches. So that's one small trick. The again thing, be cautious in pseudoexfoliation. If you overfill or if you push more OVD, it can go across the zonules and into the burger space and then cause a positive pressure or a misdirected fluid misdirection syndrome. So be wary of that. Use very little, if at all you need to. It's a last resort, not the first resort. Especially in intumescent cataracts, non-dilating people, you're unlikely to damage the capsule. So just inject a little bit of dispersive OVD so that you have a space, then put it. Because I have had situations where, because the zonular weakness is such that the fluid transgresses across the zonules and you have positive pressure by the time you remove the nucleus. When you touch the capsule, that is the time when you really know what is the health of the zonules. So when you try to tear it, the tearing will be very less. You can see the wrinkles around the capsular edge when you're trying to tell. And in these are the stages where hydrodissection is extremely critical. So once you do a rhexis, the most important step is to do a good hydrodissection, because invariably we lose the bag because the corticocapsular adhesions are still not broken enough. And that is the reason why we end up causing a lot of stress during the nucleus management. So spend a little time when you're doing hydrodissection. So I want to confirm it. And then usually in such situations where the zonular weakness is quite significant, my preference is to insert the CTR early rather than delay it, because most of the stress on the zonules happens during nucleus management. So if you already lost the zonules, by the time you are emulsifying the nucleus, then we lost the bag. So my goal is to stabilize the bag at the earliest opportunity rather than delaying it, especially in cases with pseudoexfoliation. So use a nucleus division of your choice. The mandatory rule is you need to be as gentle as possible. One option of, you can always use capsule hook as well if the CTR alone does not stabilize. But invariably, most of the times, in moderately weak zonules, early insertion of CTR does the job here. So you're worried about two things. The pupil management is relatively easy. Managing the weak zonules is a more trickier part. And believe me, the case is really not over until the entire case is done, because even during cortex aspiration, you may have surprises. So my practice is predominantly rural. So every day, my OT list will have at least 20 to 30% cases of these only. These are hard cataracts, pseudoexfoliation, non-dilating pupils. And there's a different way to manage them. Only thing is you need to have a little bit of patience and a sort of a planning in these cases. Again, the moment you touch the capsule, that is where you do it. And in these situations, using a forceps always is a good idea than using a needle. Because you can tear it in a much controlled way and cause less of a stress. Again, I have to stress that, do a good hydrodissection. When you're trying to mobilize the nucleus, you see that the bag also is moving. And this is the time where you want to stabilize the bag. Either use a capsule hook or a CTR. The CTR usually is the first option because I don't want to make the 4 incisions again to hook it. But once you put a CTR, if it works, fine. If it doesn't work, fine, then I'm going to use a capsular hook again in this situation, because the pupil is well dilated and I'm able to see the rhexis margin. So I have situations where I've used both the BX device as well as capsular hooks along with the CTR inside. Again, you need to be as gentle as possible in your nucleus division techniques. And it is not really that difficult to strip a cortex with a CTR inside. This should not be a reason for postponing a CTR, because the cortex removal is difficult. Because by the time you reach the stage, there may not be a bag left or this thing. You just have to do a tangential stripping. You can literally see that the cortex can be stripped across the CTR. So this should not be a reason for postponing it. It is not a big deal to aspirate the cortex with a CTR inside the bag, because by the time you reach the stage of cortex aspiration, the bag would not be there at all. So what is the point of postponing it? So in these situations where the zonules are so weak, my preferred technique is the IOL trap technique. What I'm trying to do is place the multi-piece lens in the sulcus here. Both the haptics are in the sulcus. And I'm going to remove the OVD and then from behind the lens and then push the optic back. So this is what we call as the IOL trap technique. I find this is a much more predictable way to secure the lens as far as slightly longer term is concerned. And I've been doing this for last maybe 6 years now. So far, so good. I haven't had a dropped lens. The problem with the putting both the CTR and the lens in the bag is after 5-6 years, we see that it just drops down. So that is the principle which I follow here. And So far, so good. It has helped me well. The one of the prerequisites is that, in these situations, you need to have a multi-piece lens itself, and the rexis has to be about 5.5 millimeter or something, so that you get a decent optic capture. The principle is the lens itself is actually holding the bag. The haptics are in the sulcus. The weight redistribution is there, so you're not really, putting everything is in the bag. The 360 degrees circumferential expansion and stability is given by the CTR, which you already put. And along with that, the haptic in the sulcus and the hydrophobic lens, which sticks onto the bag very well, pulls up the bag. And hopefully this would prevent the long-term displacement of the lens or dislocation of the lens. That is my idea here. Thank you for your attention.
I think those are some really lovely videos, Dr. Deepak, so very nice. Dr. Malkan sir, can we have your opinion or your tips on how you would handle a similar situation? Dr. Nitin Malkan sir, are you here? Okay, we'll switch to Sandeep sir. Sandeep sir? Okay.
And Nitin is there.
Yes, sir. Dr. Malkan, you can go ahead.
It's very well shown. Yes, these are problematic cases. The problem starts with the small pupil, and Dr. Meghoor has shown beautifully how to manage the pupil part and the rexis. Now, the best point what you have brought out is final placement of the IOL. It's an optic capture, keeping the loops in the sulcus, and that is a very good step, because most of the time in pseudo exfoliation, you get zonular dehiscence and subluxation of the IOL or dislocation of the IOL in the back, in the posterior vitreous sometimes. So that was a very good point brought out. Otherwise, it is well covered.
Dr. Nagvekar sir, would you like to share some tips with us?
I think all my ideas are already covered by Deepak. Yeah, I think there's nothing much more to add, except that, I want to caution, the youngsters when they start with doing small pupils. So if there is a history of tamsulosin usage and the pupil is not dilating, you should be prepared with a device straight away. I've seen sometimes people go in and then they start hunting for a device. I think there's no point in stressing yourself, because this person is definitely going to have a problem. So you should be ready with the device, whatever device you are comfortable with. It could be rings, it could be hooks. Of course, Deepak has got his own preference, and I also have my own preference as to which device I will use. But this BX ring is a very, very good device. It can be used. But the only problem with the BX ring is that if the pupil is extremely rigid, it sometimes doesn't work. In those cases, I prefer to use a Malaysian ring. But this thing about the IO trap technique is an excellent technique. I have employed it so many times. And I always counsel a patient with pseudo exfoliation. If he asks me for a premium IOL, especially if they want a multifocal, then I tell them that maybe this is not the right lens for you, because we don't know whether it will stay there forever. I put them a monofocal and I put them a 3-piece, just like Deepak has done. And I think that's the best and the safest way to go around these things.
Does anyone have any experience using the iNova? That's a new pupil expansion ring from Aurolab, which is something like a modified Goddard's ring.
Yes.
I have not used.
I have used in 3 cases. Of course, there is a small learning curve. And at the end of it, I always felt that I should have used the hooks. So probably it's a good device, but there's a learning curve, because it's very difficult to put it, behind the iris. It's not as easy as Malukin ring or BX.
Deepak, do you have a preference for BX ring or Malaysian, or is there a particular case in which you prefer one over the other?
Yeah, so Malukin, only because of the cost, is a deterrent for me. The advantage of Malukin is that the pupil dilatation is very wide. Okay.
Yes.
The biggest disadvantage with BX is that it doesn't dilate well.
That's exactly. In rigid
you
pupils,
have to work with 5.5 millimeter. That is the limitation of BX device. The reason I use it, it's affordable most of the time for me. The Indian version of Malukin is the Gupta ring. Okay, it's just like Malukin, and it is much more, expands the pupil better than your BX device. It is affordable as well. But the advantage of BX over these is it is uniplanar. Removing it is very, very easy. Okay. Whereas when you want to have a Gupta ring or a Malugin ring, they are biplanar. And removing them, especially in eyes with very small antechamber, a floppy iris, can sometimes, especially for beginners, it can be a sticky problem. Okay. That's one issue. But the advantage, if you want a bigger dilatation, then you should go for a Malugin ring or iris hooks. But if you're able to manage in 5.5 millimeter, then BX is the best device. So clear-cut differentiation is there, clear-cut differentiation. For example, I'll give an example. You have a peripheral PC tear. Okay, you are not able to visualize that. Then you cannot use a BX device. You have to get it out and use an iris hook there. Or if you want, suppose a situation where Rexis, you're not sure it has gone out. It might have gone out. These are situations we want to see the peripheral part. These situations where these things might not work. You have to again change it to use an additional hook there.
There is a question from the audience. Dr. Suvira, could you take it? It's about what settings should we keep in hard cataract, and what are the phaco settings that you would recommend?
So that again, I find a very strange question, because all different machines have all different kinds of settings that they afford. So one would be ozil based, but let's look at more likely than not, people will not be using an ozil straight away, perhaps as juniors. So I think I would always keep a power. Now, different machines have different delivery. So I would use a power which gives me enough energy to impale the nucleus without pushing it, and the same amount of energy, at least about 40% or 45 sometimes, which will enable me emulsify that nucleus. I do a direct chop. So for me, vacuum is very important. So I work with a vacuum as high as I could, so I can use more of the vacuum, less of the energy, provided I don't get surge. So something like 300 or 350 millimeters of mercury. And I use a flow rate now in a patient like this with a pseudo exfoliation. Anything where there is a possibility start off or a possibility of a compromise, I would go with a lower flow rate, because that slows me down. In each of the cases, Dr. Megho suggested how we have to slow down. So a flow rate of maybe 20 to 25 will give me 25, perhaps would give me adequate control. And in terms of power modulation, I guess if I'm doing a direct chop, I would go with a burst mode, which would allow me to impale, lollipop, and hold on to the nucleus and give me the fixity at the depth I want to thereafter mechanically subdivide it with a chopper. And then for quadrant removal, I'd go with a hyperpulse mode, wherein I'd have a bit of a power modulation. I won't necessarily go with a 50 on and a 50 off, because that might be too much energy, but it may be okay in a hard cataract. And then if it's ozil, I'm not very familiar, so the others can speak. I'd just like to add that my preferred choice for dilating a pupil is almost always iris hooks, because even though it's 4 more incisions, they're really tiny, astigmatically neutral incisions. I feel the intraocular manipulations when you use iris hooks is minimum. And I think you can have a sectoral, and you can quantify the extent of dilatation you want. So I think you should be very good at using iris hooks before moving to anything else. This is just a personal preference. Yeah. Thank you.
Thank you. Shall we move on to the next video, sir?
Yeah.
Sure.
Okay, this is, yeah. Okay, CTR, I think I'll just begin by, most beginners should start using CTRs in their regular cases, okay? So this is one of my trainee who is having his first insertion of CTR. And you can see that, they find it very difficult to just get used to the consistency and the feel of it. So the first message here is, don't try this thing on the first subluxated lens or a Zobler dehiscence. You should put at least 5 or 6 in your normal cases, then only you'll come to know how it feels. Now, this is his first attempt, and we can clearly see that, he's overwhelmed by the situation. And first time it goes into the sulcus, and because he's not using the right technique and he's overwhelmed by basically the situation. So you need to get used to the feel, the consistency. As I teach always, one has to remember what are the things. I always insist that you should write down this list, what can go wrong before you learn any new technique. So for a junior who's putting his first CTR inside, make a list what all things can happen. Just imagine them and be ready with them. Everything can happen when you're trying to put in a CTR. So starting from difficulty in handling to causing a posterior capsular tear or rexis tear, or in fact, even you can break the CTR or CTR can be lost into the vitreous as well. Everything is possible. So write it down, and then you can you're well prepared to identify and minimize that complication. The first tip here always is to try it in an empty bag, in a normal bag. Fill the bag with a lot of OVD, preferably sodium hyaluronate, simply because it pushes the bag, maintains the space well. So even with if you're not very convenient, clumsy with your initial part, you can still negotiate it quite well. So I prefer to use it always through my side port here. And I always insist that the left hand has to support the CTR when it is going down. By this, you are able to put less stress on the capsular bag when the CTR is being threaded into the bag. The first tip here always is to try it in normal cases in an empty bag. Fill it with sodium hyaluronate so that the bag is maintained well. Okay, so you can use HPMC as well and learn to hold it and feel it. How it is. First time you should do a dry run only outside the eye itself. Just feel it a couple of times, and then maybe you try to insert. So this is my standard preferred technique, trying to use it through the side port. And most of my trainee or fellows, they do find this technique quite easy. The another challenge is people are intimidated when they want to use a CTR with the nucleus in situ. So let's understand the problem, what can happen here. Basically the intimidation is because there is no space here. So one trick here is to use a little bit of OVD under the intercapsule. You create some space, and then you're going to thread the CTR inside. A well-stained intercapsule is a prerequisite so that you really are sure that the CTR is really gone under it and not above it. Okay, this is one way. Just use a good magnification, because many times I've seen my fellows would be putting it in the sulcus all around and the bag would be still coming up. So be sure that it is going inside. The second sign it is in the bag is the capsule tents where it is engaging. So because these are all eyes are sick eyes, the zonules are not so healthy, a bimanual way of maneuvering the ring into the bag is a much more safer option. And you're always in control, and then you just disengage by using the second instrument and leave it in the bag. You're doing it in a very controlled manner. This is an intraoperative zonular dehiscence. Again, you want to stabilize that part of the bag before threading your thing. Two ways to do this. Use sodium hyaluronate. It is much more heavier, stays in the eye, maintains the space, push it so that it can go there. Second option always is you can dial the nucleus into that position. So that also acts as support. Now, again, you have some part of the thing, nucleus, but you can still thread it inside. The best portion would always be start the insertion of the CTR by this. If you have an injector with a CTR, that would be the most ideal way to do it, because you can start injecting the CTR at this rate and then you go ahead. In this case, my insertion is slightly away from it, but it still is okay as long as the bag is very well stabilized by a good OVD. Now, in this situation, what I realized was the sizing of the ring was not appropriate. This is a 11 to 13 ring. We can still see that the area of the zonular dehiscence is still not totally supported. Now, thankfully, in this case, the advantage the pupil is extremely well dilated. I can still go ahead and hook on the ring and then place it appropriately. And the other situation is, it's never too late to insert the CTR. This is the rexis size. It was already circular. The moment I put in the lens inside, the rexis size, the rexis shape changes. This suggests that there is a zonular weakness and it is being oblong now instead of circular, simply because it is being stretched by these two haptics of the multipiece lens. So it's the indirect evidence that the zonules are not in great health. So in this case, again, I go in and refill the bag with OVD and then the CTR is pushed. The idea is to give a circumferential support to the back, not just at 190 degrees as was it being done. Again, tenting of the rexis does suggest that you're in the right plane. Use a second instrument. A dialer which is slightly longer does help in negotiating the ring into the back. So some of the errors can happen even in the most experienced hands. This I had in a couple of years back. Everything is going fine, and during this maneuver, I lose the grip of the CTR suddenly as I'm trying to maneuver it inside, and my left hand, which is supporting, slips off. It comes off, and now what happens? The CTR has gone into the angle. A mistake which happened was the second instrument was not supporting it well enough, and that is the reason why it just slipped out. Even if it slipped out, if my second hand was supporting it well, it wouldn't have gone there. Now, what is the situation here is the ring has gone into the angle. Okay, the ring has gone into the angle, and how are you going to fish this back? So what is the situation here? Half of the CTR or more than half of the CTR is sitting in the angle, and half is in the back. Now the problem really is I'm unable to trace it. Okay, I can't physically go ahead and try to search the CTR here in the angle because we know that the peripheral chamber is very shallow. When you go and fish around there, there's every chance that you're going to damage the endothelium, and there's always a risk of inducing a Descemet's membrane detachment. So how are you going to deal with this situation? So one trick here is, trace the entry point of the rexis out of the CTR out of the back. How do you trace that? Is look at the kink. Where is the kink here? The kink of the thing. That is where your CTR would be there. That is the point of entry of the CTR into the back. That is I'm going blindly and trying to hook it. And this is where I get the CTR. Now, once I get the CTR, I get a hold of it. I'm not going to leave it now. I'm just going to keep it hooked. And then with my second hand, I'm going to use a micro forceps just to engage it. And now you can see almost 2/3 of the CTR is still outside. So I'm going to use 2 micro forceps, hand on hand, slowly but surely, I'm going to thread it inside. So this was a very unusual situation for me. After even using thousands of CTRs, I still had a surprise. But this is one way. So keep a micro forceps handy in such situations and always try to trace it. So recently in India also, we have got access to these CTRs with injectors. This is the Madhu Instruments one, which has got the left side opening variant and the right side variant as well. I believe the Aurolab also have recently introduced. I have not used them, but this is really handy, to use, very easy. So the advantage here is that if you have a left-sided subluxation, you can direct it and use the left-sided ones so that you support the area of the zonular dehiscence first rather than doing in the other way around. This is a much more neater way to do it. There's not much of a learning curve. I didn't find much of a learning curve. Only thing is you need to always use a second instrument to disengage, okay? So you need to learn a second instrument to disengage. And that's it. So you have a left side opening and a right side opening variants. Aurolab also has a one, but I'm not used it and no experience. And also you need to understand there are subtle differences in the two CTR manufacturers, which we have, Aurolab and Madhu Instruments. The Aurolab hole is slightly smaller, whereas the Madhu Instruments, the hole, engaging hole is slightly bigger. So if you're using an Aurolab, make sure that the synth tube which you're using is very narrow, otherwise it gets stuck there. The Madhu Instruments is slightly larger. And even the consistency of the two CTRs is slightly different. The Madhu Instruments is much more springy in nature, whereas the Aurolab variation is much more, I should say, rigid. But both of them work very well, not an issue at all. So you just have to be aware of certain things like this. So, it's a great tool for us as cataract surgeons, and it really makes surgeries much more safer in most situations. And I would encourage every resident or trainee surgeon in the early part of their career, try to use them first in normal cases. They should help them. Thank you so much for attention.
Thank you so much. I think that was some amazing videos and great learning. Hane sir? So are you here? I think he's not here. Dr. Suvira, would you like to add your tips for such a situation?
I would do exactly the same. I've done it in one case and made a video of it as well, where there was no other way to, in the last case, to manipulate a CTR that's subluxated. How do you then hold it? So I've also done the same thing, wherein under a cohesive viscoelastic cover, once I hook it out, I don't let go and I do an intraocular hand on hand to take it in. I also agree completely that using an injector is a far safer way, because we all know that a CTR being a rigid instrument of PMMA, you're going to get it in a bag that's compromised. It is often known to make matters worse because you're taking it from the plane of the incision into the plane of the capsular bag. So if you use an injector, I find start the injection at the level of the capsular bag deep to the rexus, its chances of then going in the correct plane and staying there without further causing zonular damage are a lot less. So the chances of damage are a lot less. We should all consider using the Madhu injector. It's a bit of a learning curve, and that's it. I guess that's it. Thank you.
In fact, even if you don't use a preloaded one like the Madhu or the preloaded injectors, there are injectors available which are something like an IOL injector, which has got a hook at the plunger. So you can load the CTR into your injector and then use it like a one with the injector. So these are available, they are reusable, and they're much more cheaper than the preloaded CTR rings.
Please let me know where I can get that. Thank you. Later.
Dr. Malkan, sir? Sir, you're muted, sir.
No, it's very well covered. I have nothing to say more.
Dr. Sandeep, sir, would you like to share any tips with us?
Nothing. I've learned something today that I've never used an injector. Can you believe it? In all these years, and of course, it's maybe with experience I can manage. But I absolutely appreciate the point that Suvira and Deepak brought out, that it is much safer to go in at the plane of the capsular rim and then inject. So you're always right in the same plane. And of course, that point about always supporting the dial, the portion of the zonules which are dialyzed first, so that, when you finally get that ring in, that is the part which is going to get the best supporting.
And I think sometimes if you've got a zonular dialysis with a bit of a tilting of the lens as well, then using a capsular hook to elevate the bag and then putting in the CTR also sometimes helps, I think, in a very bad way.
True.
Well, in such cases, the Sioni rings would be, if you use, is much better if there is a zonular dehiscence, rather than only using the CTR ring.
It depends on the number of clock hours, Nitin.
Yes.
If it's less than 3 clock hours, I think you can just put in the capsule.
There's a question about tips for anterior vitrectomy. Deepak sir, are you going to be taking a video on that?
I would ask the opinion of the moderators. It is out of syllabus because we are running short of time. I'm not sure. I would be ready to speak for an hour, but the moderators have to decide.
I think we have time and people are interested. So Deepak, you could go ahead and show us the tips.
Absolutely.
No, I don't have a video ready on, but it's on my channel. But what was the question on anterior vitrectomy?
Tips for anterior vitrectomy.
Okay. I think the first thing would be to diagnose your PC tear at the earliest, number one. Second thing would be, if at all you can prevent and, minimize the vitreous prolapse. So if you can diagnose it early, you can minimize it by just pushing in dispersive OVD from the second hand, so that you don't enlarge. See, the goal of doing an anterior vitrectomy is twofold. One is to remove the prolapse vitreous. Second is not to cause any traction on the vitreous base. Third would be not to enlarge the PC tear. So to do that, I want to quickly summarize is that, start with the low bottle height, stay in your vitreous with triamcinolone acetate, position the cutter at or below the level of the PC tear, and then start cutting. First with the port down, and once your port down is done, and then you sideways, and then lastly you turn it anteriorly, so that the cut vitreous, which is anterior, you pull it out. By doing so, you have a lesser chance of enlarging the PC tear. So this is in brief, because it's a 1 hour session I can take, but it is in brief what I can summarize.
Thank you, sir. So I'm trying to look for any more questions. Yes, there's one more question from somebody from Bangalore. I'm finding it hard to make a tunnel. Can you give us any tips for the same? I'm assuming they mean the phaco main wound.
Facies tunnel or phaco tunnel, I'm not sure.
Phaco tunnel, I presume, because this is a phacoemulsification class.
So I think the most common mistake is you're creating a very short corneal entry. You don't have enough corneal valve there. The best strategy is always to move the eyeball slightly away from you, and then you enter, so that you are able to create a short tunnel and then you enter. So this ensures that you're not having a premature entry. Turn the eyeball down and then you enter. Stabilize the globe with the second instrument.
Yeah, and I would say that try and use the fresh blades always. Let us not compromise on the blades, reuse it, because the well begun steps that is so very important. Well begun is half done. So making the proper wound, as you have said, you struggle with the blunt instruments and you mash up the wound, and then the sequelae follows, and you keep suffering all throughout the surgery. So always try and use best quality sharp blades.
True. All right. So I think with that, Dr. Deepak sir, do you have any more videos that you would like to share with us before I assume that we have
topic which was listed there about Rexis rescue? If we want to continue, we'll do other.
Yes, we can.
We can continue.
It was a listed topic there.
Yes.
Yes, so we can continue if you are okay with that. And
the
the panel
time is 9:30. I'm sorry, it has extended.
No problem at all.
That's fine.
I think people definitely would want to wait.
Okay, then I think. Okay, this is going to be the last presentation. I think, again, it is aimed at the most common mistakes what beginners do when they, trying to salvage a Rexis which is threatening to go out. Okay, so this is the classical little maneuver, and this is one of the
બસ હવે 10 મિનિટનું બાકી છે.
Okay, so this is one of my residents who's trying to. Okay. So he's trying to do a Rexis, but he has not realized.
Dr. Malkan sir, you can mute yourself, please.
ચાલો તો આ પૂરું થાય ને એટલે કહું તને કે આવા જેવું ખરું.
Dr. Malkan sir,
1 minute મારો ડાઉન है. Yes, can you please repeat the question?
No sir, just requesting you to be on mute. That's all.
Okay. So this is one of my trainees who is doing this surgery, and the Rexis is already hinting that it is going away, and you can see the corneal folds which are appearing, the AC shallowing. This is a sign where he has to stop, and then you have to reintroduce OVD, but the surgeon is continuing because experience, and then he realizes he does refill the chamber with OVD, and then even at this point, there is a hint that the Rexis is now beginning to hint, okay? But he is still not changing his strategy. He's going in the same way. And now he's become desperate. At this point, you can see it is still there is about 2 millimeter gap between the equator and the tear which is there. There's still an opportunity to retrieve the Rexis. So wisely he goes and chooses the forceps, refills the OVD. But his maneuvers are wrong here. What maneuvers are wrong? He's trying the pull-in technique, the little maneuver. But what is wrong is the way he's handling the capsule. Okay, so eventually, as was destined to be, the capsule does go out. So now it is too late. You can't retrieve it back at this stage. It's already reached the equator. The only solution is just cut it and then tear the remaining portion. So let us analyze what is the mistake which happened here. Okay, the classical teaching, you need to understand the concepts are wrong by wrongly understood by the youngsters. You need to have a flap which is flat. Okay, you need to keep the flap flat. What the surgeon is doing here is folding the capsule. He's folding the capsule and trying to pull it centripetally. Okay, that doesn't work here. So the first principle, this is the concept error which most novice surgeons have. So they think that just using a forceps and pulling it is going to help us. It's not going to do that way. So let's learn how to rescue it in the right way. So when you do it, it's invariably going to run to the equator. If that was the case, and second is the angle of attack. Even at this stage, if you had chosen wisely, if you'd used the second port, this port, and used a different instrument, and the angle of attack would be different, then probably again still the rhexis could have been saved. He chose the main incision rather than using through the other side port incision which was available for him. So let us go through one such case here, and this is an intumescent cataract, and I feel it's in control and it's all going fine. So when you become greedy. Now, when you become greedy, you feel that, okay, I can enlarge. And by this time, it will startly hint that it's going away. Now, this is the point at which trajectory at which you need to understand and stop now itself. Now, this is the moment. So what I'm doing here is I'm keeping the flap flat here, okay? The always option is come back, refill the OVD and repeat the maneuver. But this usually works well here. So you just keep the flap flat enough and then look at the maneuver it is being pulled. It is being pulled towards the center of the eye, the centripetally. Then only you can literally see that you can tear the rhexis from the periphery into the center. Okay. The first rule is what I did was I kept the flap flat. And once now it is out of the danger zone, now you can very safely, you can use again the shearing method, or you can just tear it as it is. Now I used first the tearing and then the shearing method. So tearing method is used when you're desperate and want to rescue it. So 2 points. First is make the capsule flat and then pull it centripetally. Now looking at the second case here, this is an innocuous looking case. There's no reason why it should be going out, but sometimes the capsule, you lose a little bit of a concentration and it does happen. Now it's heading now to the periphery. Now let me pause here and see now it is almost gone under the iris. Now, what are the strategies which we are going to use it? First thing is timing is critical. You need to acknowledge that it is going bad and stop as early as possible. Now, here in the situation, the complicated situation, the flap is stuck in the wound. There is a high chance that the rhexis can extend to the equator when you're just trying to push in OVD itself. So first thing is I use a side port instrument to just make it flat here. And then you're going to introduce OVD so that it doesn't come out. Now it's going to remain flat. And then what should be the angle of attack? Should I use the main port? No, it's not a good idea. There's a chance the flap can still come into the main. So always I prefer to use the second side port which is there. It gives me better access, and that is the maneuver which I'm going to do it now. So use the micro forceps here. Again, you just observe that the capsule is kept flat here, kept flat, and you pull it centrally towards the center of the eye. And slowly but surely, you can see that the rhexis can be reined in, and you prevented the rhexis from heading on towards the equator. Again, the principle of, 2 things, keeping the flap flat, and the second would be pulling it centrally. So this is another case. I don't remember what happens here. Let me see. So again, it is going on well, pretty well, should be fine. And these are all not, these are inexcusable errors. There's nothing wrong with the cataract here, and it shouldn't be a problem at all. But what happens, the patient, I think, just jerks a little bit, and it just goes. So the fixation, my error was the globe was not fixated well enough. And in this moment, so the point which you want to note here is I'm not injecting viscoelastic here, okay? When it goes, the viscoelastic has to be injected here. There's a definite physics here. If you inject here, it's going to increase the intracapsular pressure, and it's going to make the rexus run away again towards the equator. So inject it away in the periphery, away from the capsular opening, not inside the capsular opening. Put it away and use a cohesive OVD, preferably like a sodium hyaluronate, so that the chamber is maintained well. So still, again, we have got multiple options, what port to choose, what should be the angle of attack. So should I use the main incision or thing? So one is always avoid the main incision if the tear is just under the main incision. In such situations, I prefer to use the side port, which has got better access. So again, stabilizing the globe was very important in this situation because the patient was anxious, was moving around. I didn't want to lose this case. Again, the capsule is kept flat, and then once you retrieve it inside, then it's all right. It's in the safe zone. Now you can fold the capsule and use the conventional sharing method of doing the rexus. So this is it. So important steps to follow again. Early identification. Timing is very important. It is unforgiving if you're too late. And refill the chamber with OVD in the right way. Don't put it inside, but put it in the periphery above the capsule. And the third, obviously, is ensure that the capsular flap is kept flat. Identify the right angle of attack and always use a forceps. Forceps is the best way, and the direction of pulling is always towards the center of the eye. Remember that, and that should be fine. So these are my small few tips. And in this modern era, with our better understanding of the intumescent cataracts, there's no reason why we should bother about having an Argentinian flag sign in an intumescent cataract at all. Okay, when you're trying to rescue, maintain the AC is critical. Cohesive OVD or dispersive OVD ideal because the chamber is maintained well. Now coming on to the intumescent cataract, there is no reason why one should have a Argentinian flag sign. The only two secrets: should have a soft eye and a heavy OVD, and most often than not, you can do a perfect 5 mm rexus in most situations, even without doing a 2-stage rexus. So that was it. Thank you for your attention, and thank you.
Karishma, you need to
Thank you
unmute
so
yourself.
much. Thank you so much, Dr. Deepak. I think those were some absolutely phenomenal videos, and it was a great learning experience. Would anyone from the panel have anything more to address or talk or discuss? Any points that you would like to be highlighted? Yes, sir.
Yeah, so just one point I wanted to add to that phenomenal cases that he showed us is that when injecting the OVD, as he said rightly, one is you inject on the capsule rather than under the capsule. And the second thing is that when you are injecting the OVD, peripheral to the expected tear and then inject over there, so that the OVD then fills from the periphery to the center. Don't fill it from the center to the periphery because that drives the rexus away into the zonules. So go beyond the expected one and then inject. You can make another side port incision if required, but go beyond the expected tear and then inject it backwards.
Right.
Dr. Deepak, amazing videos. Congratulations. I just want to ask you one question. In some cases, the zonular insertions are quite, anterior. And then even the 5.5 millimeter rexus is difficult to perform. Any clue on that when the zonular insertions are anterior?
Yes, sir, but nothing alarming, nothing to worry. Okay. One way is just to use a Sin's cube to just swipe it over the insertion edges. Okay, you are just going to disinsert some of the zonules around that 0.5 millimeter or something, and then you can go ahead and do it rexus. It's not an issue. You can literally feel it and just scrape it around. So if you do that, nothing happens to the rest of the zonules. Okay, even if you just pick on those areas and just clean it up to 6 millimeter zone, and then you go ahead and do it. And many times, even if the zonules are involved when you're tearing, nothing happens because you don't find that the health of the zonules, generalized health of the zonules is very bad. So even if you tear a few zonules when you're doing it, if they come in between, it wouldn't really jeopardize the bag. And if needed, always support with the CTR.
And Deepak, sometimes the capsules are very tricky. When you're tearing and doing the rexus, it doesn't go curvilinear. It goes almost like a postage stamp,
Yes, sir. Yeah. Today itself, I had one case. I think I attribute it to the zonular health. Okay.
Yes.
Because when you tear, it is basically tearing against the traction which is induced in the entry capsule by the zonules. Whenever this traction is not there, you don't get that linear cut which you used to get. You get a stamp-like thing. And my understanding is that it is related to the health of the zonules rather than this.
Yes, I perfectly agree with you there, because it is the vector forces, you are pulling on the inner side and the zonules are pulling the capsule outer side. So the resultant vector carries the tear circularly. So when the one pull is little less from the zonular side, it results into stamp, irregular access.
When I have cases where I've got anti-placed zonules, and we do know that sometimes they can cause a bit of resistance. In cases like that, under a cohesive viscoelastic cover, I find that I have more control using an intraocular microforceps rather than a cystotome to navigate the rexus when I have such a situation. And I think for students to remember regarding the last point about how a rexus doesn't seem to be going the way it should be going when you're navigating it with the cystotome, is that students need to look at the tip of the cystotome. Any tiny bend in the cystotome tip, either this way or outwards, especially it tends to be inwards, because that is often occurred because you've got a bad, needle holder, or you've got one bend and then you try to manipulate it, which you never do. You just chuck it and take a new needle. If you have a tip which is not a perfect tip, then also the rexus can sometimes be erratic and you don't know why it's not turning out the way you want it to. Thank you.
Another point with cystotome is that it's very important the length of the bend, the length of the bend of the cystotome which you're making, because in case especially for the newcomers, the beginners, if the length of the bend is not good enough and you're using the hub of the needle instead of the tip of the needle, very often you run into problems. So it's very important to see that you have the ideal size bend while making the cystotome.
And one more thing I wanted to highlight here is to begin the tear more towards the center of the capsule and then go to the periphery and have a bigger radial cut, and then you can get a very good flap which covers itself and goes out. Sometimes, the cut happens just in the periphery, and if you try to initiate the rexis, then you don't really get the good hold of the flap.
Okay.
You get it?
Yes.
That's right. With that, I'd really like to thank all my panelists. And thank you, Dr. Deepak, sir, for extending your talk for another half an hour beyond what we requested you for. It was an amazing session, and I think we all had a lot to learn. Thank you, everyone on the panel. And with that, we'd like to thank the BOA for giving us this opportunity to conduct the first of our masterclass series. Looking forward to a lot more. Thank you, everyone.
I also take this opportunity to thank all the audience who are on all our 3 channels, the YouTube channel, the Facebook channel, and the web link. And a small point is the entire webinar, this particular one and all the other masterclasses will definitely be available on the BOA YouTube channel. So people can go back and refer to these fantastic videos and continue the learning experience. Thank you. Thank you, Dr. Deepak and all the panelists.
Thank you.
Thank you, everyone. Thank you.
Thank
Good night.
you.
Thank
Thank
you.
you. Good night to all.
Good night.
Bye.